just on time. Ladies and gentlemen.
Thank you, sir. Thanks to organizing committee and chairperson and panelists. Topic given to me, how to make differential diagnosis of ST elevation in OPD setting. And I think this is the most important work. While working in a secondary care center, working in a OPD, working in a remote place. Those who are not in that institution level, how to make the differential diagnosis. 2-3 things are very important. Not always acute myocardial infarction is there. So at least how to develop ST segment elevation. This ST segment of cardiac cycle represent a period between depolarization and repolarization of left ventricle. In normal state, ST segment is isoelectric relative to PR segment. Coming to causes of ST elevation in myocardial infarction. We know the important is the ST elevation myocardial infarction of ST elevation. Rather than this, few important and practical tips that we encounter daily in our practice, like pericarditis, myopericarditis, left ventricular hypertrophy, left bundle branch block, early repolarization, electrolyte imbalance, rarely tachycardic cardiomyopathy or even persistent coronary spasm. But 3-4 things is a very common that should be, make to easy differential diagnosis in day-to-day practice. This is the approach to patient of chest pain, thoroughly important that taking the history of the patient. Why it is important? So many patients in our OPD working in a secondary care center, they came with a typical symptom of ACS, but there is no change in ECG. What to do that kind of patient? This is important to save their life. So this is important to identify symptom and give them loading dose. Taking the history and examination, getting for a surface ECG. If STMI is there, go for the STMI protocol. If non-STMI, go for this. If there is some diffuse changes with some systemic symptom is there, think of pericarditis in early stage. If there is non-diagnostic ECG, you go for the repeated investigation, and if there is some arrhythmia, you go for the arrhythmia protocol. Or TP segment or PR segment, ST segment elevation is the measure at J point if relative to PR segment, at least 0.06 to 0.08 from the J point if related to TP segment. How to make approach of ST segment elevation? There is a different guideline, and there is a, roughly say there is a minimum criteria elevation of 1 mm in consecutive bleed. HA, GC1, GC2, Gusto, TIMI, and Minnesota code, there is a minimum elevation of 2 mm in consecutive bleeds. In the same way, minimum ST elevation in the limb bleed 1 to 2 mm is there. Time to onset in the ECG is the important, and how to get it, that's the important. And if you see the outcome in the inpatient and OPD patient is entirely different in the outcome. If you see the age characteristic in STEMI patient and output patient with a different group and different comorbidity, diabetes, CKD, sleep apnea, COPD, and so outcome is seem to be difficult. Coming to what about sometimes AVR changes in the AVR post-systemic approach to evaluate the patient presenting with the ST elevation AVR lead, usually neglected lead, and sometimes this presented with left main stenosis. And usually there is left main stenosis there, patient presented with a hemodynamic stability. So patient presented with the ST elevation with the AVR leads with a diffuse ST diffraction, always try as high acuity to go for this, check the hemodynamic stability, resuscitate the patient, and follow the ACS guideline, whatever. In OPD setup, what to do? We cannot go for this, thrombolysis, even pharmacoinvasive strategy. So at least you go for the OPD protocol and give him loading dose and heparin. Coming to how to differentiate from the myocardial infarction, from the pericarditis, from the LBB, from this ventricular overload. So we will see the elevation, magnitude of elevation, morphology, distribution of QRS width, and the other features. Morphology of ST elevation, we know convexity upward is a characteristic of this ST elevation myocardial infarction. If it is a concavity, not the very much suggestive of the STMI. Then benign early repolarization is there. Characteristic of benign early repolarization, ST elevation less than 2 mm, concavity of the initial portion of the ST segment, notching or slurring of the terminal QRS complexes, symmetrical or concordant T-wave in large amplitude, widespread or diffuse distribution of ST elevation, and relative temporal stability. Distribution we know characteristics, what anterior wall am I, anteroseptal, lateral, inferior wall am I, and if there is a diffuse changes in the ECG throughout the precardial leads and the limb lead, this is more suggestive of pericarditis rather than with the suggestive systemic symptom and the quite younger age of the patient. This is a changes in the pericarditis. There is a 4 stages of pericarditis. I think we will go back. So, this is the stage of pericarditis, stage 1, 2, 3, 4. Stage 1 is that in the first few days to 2 weeks when this ST elevation with the PR depression. In stage 2, there is normalization. In stage 3, after 2 to 3 weeks, then this lost up to several weeks, and there is a T-wave inversion, and there is a last stage where there is a resolution of this T-wave, gradual resolution. This is stage 1 pericarditis. We have shown this PR depression is there. Stage 2 pericarditis is there, isoelectric, there is no STT changes. Stage 3 pericarditis, there is a T-wave inversion, diffuse T inversion in all these leads. So, ECG changes of pericarditis versus benign early repolarization, this need to differentiate. So, both demonstrate early concavity of the upsloping ST segment or T-wave. PR depression in pericarditis is not BR, ST to 2 ratio, ST to ratio more than 0.25 in this pericarditis. Brugada syndrome, I think this is the congenital anomaly presented with the right bundle branch block, ST elevation limited to right precardial leaves in V1 and V2, saddle shape or cope shape ST elevation. This was first described by Brugada. Syndrome has been linked with the mutation and sodium gate channelopathy. This is the characteristic pattern of Brugada syndrome. Patient presented with RBB pattern with RSR pattern, not RBB of small r pattern usually that associated ST elevation. QRS width in the LBB, this is the usual problem in the ECG setting. Patient presented with the LBB, either this is of the ischemic origin or no, this need to differentiate it. And there is a Sargosa criteria for differentiation of this ST elevation or changes. This is because of ischemic or non-ischemic origin. This is a long list is there to how to differentiate, to difficult to read it. But when you go for this criteria and when you go for the scoring of this criteria, so ST elevation is more than 1 mm concordant with the QRS complex, this is score is the 5. ST depression of more than 1 mm in V1, V2 and V3, score is a 3 point, and ST elevation is more than 5 mm and discordant with the QRS complex, score point is 3. Acute myocarditis with this LBB presentation. Sargosa criteria score of 3 or more suggested of the patient is likely to experience acute myocardial infarction based on the ECG criteria. With a score less than 3, the ECG diagnosis is less certain, requiring the additional evaluation. Coming to left ventricular hypertrophy, we know there is a Sokolin-Leon criteria and this Cornell voltage criteria. It is easy to diagnose left ventricular hypertrophy with the ECG and having a very good specific value also with this. The important is how to differentiate. So, practically we know there is a asymmetrical T inversion and STT changes there in the left ventricular hypertrophy. So, ECG change in left ventricular hypertrophy versus acute myocardial infarction is initial upsloping of elevated ST segment is frequently concave in left ventricular hypertrophy as opposed to more likely flat or convex ST segment elevation in ACS. T wave is usually asymmetrical in left ventricular hypertrophy opposed to symmetrical T waves in this coronary ischemia. So, conclusion, not all ST segment elevation are due to ST elevation myocardial infarction. ECG remain a good diagnostic tool, but must be correlated with clinical history and physical examination. Certain characteristics of ECG changes may aid to correct diagnosis, morphology, distribution, associated QRS complex, and the voltage forces. Thank you, and all of you are invited in this BPCon 2022 on the same venue in this September 9 to 11. If I will conclude in my terms, I am working in the OPD setup at secondary care center, patient coming with the ACS from the remote places and they don't have much facility like I am working in the OPD setup and there is no ECG change. If ECG change is there, I am giving loading dose, I am giving heparin, sending patient to institution level. If there is no ECG change, this is my humble request that Identify the symptom is the very important to save the life of the acute myocardial infarction, because if we are giving the loading dose on the right time, we are going to reduce the mortality and better care on the tertiary care center. Thank you from my side.
Thank you, Dr. Ansari. Ladies and gentlemen,
Compliments to the committee for selecting such good topics and for the speakers for doing absolute justice to the topics. Monica, you want to start the discussion?
I thank you all the speakers for their wonderful presentation. I would like to ask a question from Dr. Sudarshan. You mentioned about Lewis lead. Can you tell us about how to take the Lewis leads?
S5 lead in this, if you place the routine right arm electrode in the right second intercostal space position, and the left arm electrode in the right fourth or fifth intercostal space position, and you might be lucky in lead 1 or 2 to find the presence of discernible P waves. So it is just a change of position of the arm electrodes.
Thank you, Sudarshan. So that's a great message. And since we have Padmanabhan really keeping an eagle eye on the proceedings, so 2 quick questions to Dr. Rupali and Dr. Daljit, if I have the permission of my coaches. Dr. Rupali, briefly just tell us, you told a good algorithm about the P wave following in the QRS, outside the QRS. Just briefly, how do you differentiate the 3 types of tachycardia from that? And after that, Dr. Daljit, where would you place a tilt table test in the your algorithm of syncope with a normal ECG? And thank you for showing such great examples, Daljit. Rupali.
Thank you, sir. But difficult to tell you, but I just simple is that if we see the R and P wave, so we have to basically see the interval of the RP. In AV and RT, usually it's a slow fast pathway, so P wave comes a little early. So this time the P wave gets embedded in the QRS, so it's either the late deflection of the QRS, we see the P wave in the form of pseudo R in V1 or a pseudo S in inferior leads. But in AVRT, this P wave takes a little longer, I would not say much longer, so it gets emerged in the STT segments. So we can sometimes see the P wave emerge in the STT segments, so STT depressions will be seen in the QRS, which is suggestive of a AVRT. In cases of atrial tachycardias or atypical AVNRTs in which go for a fast slow pathways, then the P wave takes a little longer to go retrograde to above. So these P waves are separated from QRS, and if we see the RP interval, that will be longer than the PR interval. So that differentiate between these 3 criteria, sir, for seeing this.
I think that's a good carry-on message. We should all remember that. Dr. Daljit, are you there?
Yes, sir, I'm there. So tilt table test, situation syncope, young patient, no family history, I would say. And every time syncope patient says that I'm standing for a long time and having a syncope. I didn't show this 3rd case which I show who had a vagally mediated AV nodal AV block, sir. I did tilt table test on this patient. I reproduced vagally mediated AV block because time was less, I didn't show. His heart rate dropped to 20. I could reproduce everything. So yes, still there is a role has come down a little because nowadays we have extended monitoring. All those things we are having, we are following them real time. But yes, these kind of patients I still perform tilt-table tests. Thank you.
And again, I was very impressed, and I'm sure sir would also agree, the terminal T wave abnormalities.
Yes, repolarization.
So that is a very, very important thing. Sir, any comment on that?
There should be one step. P wave seen, yes. P wave upright or inverted. That is missing in the algorithm. So that you modify in your algorithm and say if it is upright, it has to be atrial, particularly in lateral 3 AVO. So that makes a diagnosis. And beautiful examples that Daljit has shown. But how frequently do you, because in younger individuals, you have to confirm a diagnosis, otherwise tilt is not going to change the management. How often you use in elderly patients? Yes.
Dr. Narasimhan using it a lot.
No,
but
that is the point. So in the tilt test is not going to help you in any situation.
volume.
Currently. Except that you probably confirm the diagnosis that you are already having, rather than reaching to a diagnosis. That is what I want to say.
So I think, sir, Dr. Rupali deliberately missed that so that at least we could have your words of wisdom in the algorithm. And so, yeah, so. Any questions from Madhuri?
Sir, I would like to discuss about the drug abutolite and all of your experience. Nobody mentioned this drug. In my personal experience, I found it in atrial fibrillation cases very high cardioversion rate, and it has been recommended in PSVT also. So your opinion, Rupali and Dr. Saran, on that ibutolite.
Mainly in atrial flutter and atrial fibrillation, it's a very beautiful drug, I would say, especially if you have a post-CABG patient. So you need not wait for very long. Atrial flutter has come to an emergency. It responds very well.
Normal ejection fraction, you mean?
Even normal, even abnormal ejection fraction, very bad heart failure. Try not to use abutolite because QT prolongation,
Yes.
VF storms is common. Never forget to give magnesium before you give abutolite, word of caution. You should have normal electrolytes. You should not have hypokalemia in these type of patients.
And
So if
beta-
everything is normal, if you have acute AFib patient is coming, if you are clot and all those things, long things are apart. But instead of using amiodarone, abutolite is a very good drug. Except for frank heart failure, try not to use, or uncorrected ischemia.
We have used some abutolite cases in our atrial fibrillation and
Yeah.
other cases. The only thing we have to do, Jaldi also said, the VTVF episodes, like we had, saw few patients going into VTVF, so that correction part should be there.
Yeah, I would agree with all those things. At one point I want to add this. Once you make a decision of using abutolite, it is actually very well being documented for atrial flutter. Its efficacy is around 70 to 80% in atrial flutter, but fibrillation it still counts to 50 and 60%. But QT is the most important thing before we do anything. So giving magnesium or correcting hypokalemia before giving abutolite is very, very important. I would like to give that message. Thank you.
Yeah, so again, post-cabbage patients, it's a great drug to use, but the problem is availability now. I don't think we have it in Lucknow at the moment.
So
And
it is available.
yeah. So maybe you can send some to
Feel-
us.
Fibricol.
I have one combined question to all. Do we need anticoagulation for MAT, number one? One of my patients, 50-year-old female, first time detected with severe MR and large LS size and presented with irregular heart rates. So in ECG it was MAT. So do we need anticoagulation for that, number one? Number two, which type of anticoagulation, whether vitamin K related or novel anticoagulants we can use?
See, if it's a predisposing, if you have to see the whole patient as they basically. So MAT, if you're seeing LA is enlarged, you're seeing if it's a chronic AF which is, or MAT going on. So there is no particular score like AF score which is there. It is a personalized, which I think we have to look for it. And echo is showing LA enlarged, there is increased risk for dying, and for the bleeding risk is that these patients should be given an anticoagulant, what the recommendation says.
It's a case of RSD with severe MR, first time diagnosed.
Any rheumatic heart disease patient, if they are having LA flutter,
No,
fibrillation.
he's not having LA flutter.
So MAT is a type of a flutter or focal. They may have any kind of, they may have focal tachycardia as micro re-entry, macro re-entry, but they don't need CHAD score unless contraindicated. They have to be on anticoagulation. If no mechanical valve, you can give DOAC, otherwise acetron.
I beg to differ because there is no recommendation for mitral regurgitation. For mitral stenosis, you have to give anticoagulation. For mitral regurgitation, there is no recommendation. You have to calculate CHAD score. That's all.
Okay, time over. Well, that's
Rheumatic
the,
heart disease with severe mitral regurgitation, there is no recommendation for starting anticoagulation without calculating CHAD score.
okay, that's the time
This
that
is
we have,
ESC guide.
Mr. Chairman. We'll have to move on to the next session.
In multifocal atrial tachycardia, as people have rightly mentioned, that it behaves like atrial flutter, so the anticoagulation should be given. But the role of NOAC, the no trial has still determined the role of NOAC in multifocal atrial tachycardia. So vitamin K antagonists are obviously the drug of choice.
Okay.
Okay, thank you.
Thank you.
Padmanabhan, I'm sorry to
Yeah,
take your
that's
permission. One small question to Dr. Sajid before we end. Dr. Sajid, in your clinical practice, non-ACS situation, ST elevation, how frequently do you see? Very in brief. No ACS, but ST elevation in the ECG, say early repolarization variant. So how do you sort of approach that patient?
Yeah, this is the common, I mean, not uncommon things. The things is if a patient presented with this chest pain and early repolarization, might of it is ischemic origin. So I am going for this kind of patient with a temporal ECG with the, biomarkers, but I never forget in my practice, I have seen, you seniors are there, I am giving desperately loading dose and my patient in front in my OPD, he get relief and he say, nahi, ab main lari nahi jaunga. No, I said, no, you will go. This is not the ultimate. You will go there because this you need to work up. So if the symptom is suggestive, I am giving even this kind of situations.
Okay,
Irrespective of relief, lari bhejna jaruri hai. So
that's the time that we
Sir,
have,
I mean,
Ms.
working on the
Chairman.
secondary stent, we can't do ultimate. So
Okay,
That's
that's
point
all the
well
time
taken,
that we
and
have,
thank you
Mr.
so
Chairman.
much.
We'll have to move ahead
Thank
with
you.
the proceedings. Thank you very much. We'd like to thank the opening panel of chairperson.